donations. The email that got sent out by the section would be a great place to put those in. But if you also have other ideas and you want to discuss, please send them out to Oyeri or me, and we can sort of make sure that these are coordinated, because we want to make sure these are scheduled by the end of next month for the next academic year. With that, we'll get started. We have an external speaker today, and we're pleased to welcome Dr. Jared Magnani, who's an associate professor of medicine and cardiology at the University of Pittsburgh. His research focuses on a critical area that's of interest to our community, which is social determinants of health in cardiovascular disease and outcomes. His work includes smartphone-based relational agents to improve healthcare utilization and medication adherence in underserved patients with atrial fibrillation. And his work specifically focuses on vulnerable patients with limited social resources and health literacy. He's also led investigations that combine electronic health records at University of Pittsburgh to examine social determinants of health and cardiovascular diseases. He has chaired the American Heart Association Statement on Health Literacy and Cardiovascular Disease, and serves as the AHA Social Determinants of Health Cardiovascular Health Committee. So with that, I would turn over the stage to Dr. Magnani. Thanks again for being here and talking to us about this important topic.
Thank you so much, Dr. Kira, and thank you to you at Yale for inviting me to participate here. I really feel honored to have been invited, and I'm so glad that we could meet. I'm sorry it's not in person. There are many of you, new and old contacts and friends, whom I would like to spend time with and to delve into some of these topics and hear about your work and accomplishments. Today's talk is social risk and cardiovascular disease, determinants, imperatives, and challenges. And as Dr. Kira said, a very important topic. It's receiving increasing attention. We're really at the crossroads in terms of understanding social risk and social determinants and its important relations to cardiovascular disease. Today, I'd like to summarize the robust evidence relating social factors to cardiovascular risk and disease. Secondly, describe the opportunities and challenges for measurement of social risk in relation to cardiovascular risk and outcomes. And I think these are really abundant, and maybe there are tools in the tool chest that are readily accessible to you to enhance your research and to increase its generalizability. And thirdly, to identify strategies to address social risk in our patients. So what can we do in the exam room and in our hospitalized patients? And also, how can we implement assessing social risk in our research programs, again, to enhance their generalizability and to enhance their value to the community? So to begin with, this is kind of the broadest lens as far as what we're dealing with, which is a study here that looked at household income percentile as tabulated by the Internal Revenue Service, returns that people had, and their estimated age at death when they were 40 years old. And I think what we can see is that on the x-axis, we have the household income percentile. On the y-axis, their expected longevity. And this is a tremendous indictment of our society, that we see very easily a gradient between household income percentile and lifespan. And the height of the vertical bars that we have here indicate the 95% interval of the estimate. Women who are in the top 1% of household income can expect to live 11 years longer than those in the bottom 1%. And similarly, men in the top 1% can enjoy a 14-year difference in longevity compared to those in the bottom 1%. So clearly, wealth brings health in our country. And again, this is an indictment of our society, that lifespan is something that comes with having more financial resources. And in turn, we permit people who are not as wealthy to die earlier. This occurs in a society which allocates immense privilege to those who have wealth in terms of the power, the status, and the different opportunities. And I think it also behooves us to ask, how do we, in our medical care, how do we perpetuate this disparity? What is it about our medical system such that we facilitate those who have a higher income to live much longer than those with a lower income? What are the obstacles such that there isn't more parity here? I find these data dramatic, and I also find them haunting in terms of the discrepancy in lifespan that we see simply by household income. What does this say about our society and what we value? And so the global burden of disease looked at 1 billion of the world's poorest and looked at high and low income regions. and found that communicable diseases in high income regions, such as Europe and North America, were much less than those in the lower income regions. However, the winner in terms of the greatest contributor to disability was ischemic heart disease. So what we see is that in the billion poorest of those who live in high income regions, ischemic heart disease will be their leading cause of morbidity. This is a message for us. And I think the things that are important here are that diseases differ by region in terms of lower and higher income. We don't have problems like dysentery, right, or malaria, but we do have ischemic heart disease, primarily in high income regions. It's the foremost cause of disability adjusted life years that you and I will see. And why is that? If wealth brings health, what we know is that with employment and with social opportunity comes the ability to obtain access to healthcare, which is insurance. These are data from the NHIS, the National Health Interview Survey. They're cross-sectional. They're from 2019, right before the pandemic. And so they're highly generalizable. And what we can see is that those who don't have insurance, they go without. They go without fundamental steps towards disease screening, recognition, and treatment. We need to keep in mind that this is NHIS data, which means that this is a random sample of individuals. And I think if we were to repeat this analysis, selecting those who had a diagnosis, we would see that the differences here between those having insurance and those who are uninsured would be far more profound. Another group delved a little deeper into NHIS data, again, cross-sectional data, and examined those who had self-reported cardiovascular disease who are between the ages of 18 and 64. And here the authors compared the effects of education, categorized as less than high school, having some high school, or having some college, income to poverty ratio, and not having insurance. And what we can appreciate is by far the biggest losers are those who do not have insurance in terms of having a general visit with a physician in the past year, and also a specialist visit, a visit with us in the past year. There's a marked difference across these three groups. Clearly, insurance contributing most to the absence of care. This is the ability to see a specialist, that is, to come to our clinic and to see us. Again, individuals who have self-reported cardiovascular disease. Specifically, the disabilities really pile up. So people without insurance, they're not getting screened for diabetes, they're not getting a blood pressure test in the past year, and they're not having the cholesterol test in the past year, all of which is guideline-directed medical diagnosis and treatment, but we're not able to deliver effectively. Again, individuals who have self-reported cardiovascular disease aren't meeting basic metrics of treatment because of the absence of insurance. So we know that as a foremost tenet in social epidemiology, that disparity breeds disparity. And this is the prevalence of the absence of insurance over ages 18 to 64, spanning the last 10 years. There is an inflection point with the Affordable Care Act, but it's very evident that there are large numbers, especially those who are not Hispanic white race, who lack health insurance, particularly American Indian and Alaskan Natives, and those who are Hispanic. And I read the other day that about 25% of the state of Texas lacks health insurance. An enormous number of people are at risk. So we still have an immense problem in terms of making healthcare even accessible to large numbers of adults between the ages of 18 and 64. So a really important question is, how much does socioeconomic status drive coronary heart disease? And what I showed at the start of the talk was the very evident correlation between income and longevity. But here is a computer simulation which is asking about the contribution of traditional coronary heart disease risk factors like smoking, blood pressure, and cholesterol, and low socioeconomic status, defined as having less than a high school education or being about 150% of the poverty level. And this is again in adults who are 35 to 64. This is simulated total MI rates and simulated total coronary heart disease deaths. And what the authors found here was that in those adults, 55 to 64, both men and women, the low SES is responsible for about 50% of MI rates. Similarly, in coronary heart disease deaths that are simulated, we see that, again, low SES is attributable to, that coronary heart disease deaths are attributable to low SES as well. So persuasive data. What happens if we try to address this? What happens if we try to improve simulated MI rates and simulated coronary heart disease deaths? Where should we aim our priorities? Here, the authors examined what happens if we intervene on low SES compared to smoking, hypertension, cholesterol, and diabetes. And clearly, the most bang for the buck came from addressing, hypothetically, low SES in terms of these disease rates. The same thing as well for coronary heart disease deaths. So we can give our patients prescriptions when they have insurance, obviously, but without addressing their social conditions, we're not addressing fundamental root causes. So moving into the second part of our talk, I'd like to describe some opportunities and challenges for measuring social risk in relation to cardiovascular disease risk and outcomes. And I'd like to talk about some individual measures of social determinants, the priority of education, which I think is fundamental and very important, both as an avenue towards increased social status and income, but also because of its important relation to health literacy, which I think is really fundamental in terms of creating parity and addressing disparities. I also would like to touch on some residential neighborhood level measures, which I think could really improve the generalizability of our research and help us understand risk. And finally, I'd like to focus on race and ethnicity, which I recognize could be essentially the whole focus of this talk, by using a case study to illustrate some of the issues and problems with addressing race and ethnicity and social risk. So where do we find our patients' social determinants of health? Well, one place we could look is the electronic health record. And this is an example patient of mine whom I treated just a few weeks ago, a 66-year-old man who has coronary disease. He has a long history of polysubstance use and alcohol dependence, and he has no permanent residence, and he doesn't have a high school education. And he's had multiple admissions, and I've seen him for several years here in Pittsburgh. And here you can see that as far as our EPIC record, social determinants of health is just vacant. And I'm sure many of you in your experience, you've opened up this page in EPIC at Yale, and what you've seen again is that there is nothing on file. I was curious that education was missing from here because I think that that is really important. But the point is that this is somebody who has obviously well-known, well-established social risk factors, none of which are documented in his electronic health record. And there has been a big push to put these into the electronic health record. The National Academy of Medicine had the call for integrating social risk into clinical care. This was a kind of a restructured approach to bring in multidisciplinary models.
Who the fuck are you?
We have the Z codes in ICD-10, but these are really of limited use. And maybe they could be effective as a marker of multimorbidity and patient complexity. And there are just a range of studies which have examined in healthcare systems the use of the Z codes for identifying these problems, and also looked in the community or in the county or region to examine what the prevalence is of these conditions. And what you can see is that it's really a bust. And so for risk factor after risk factor that you would recognize as being important in terms of evaluating social risk, it turns out that the Z codes are not even documented in healthcare systems that are using them. I can say here at the University of Pittsburgh that there is very, very limited use. So this hasn't worked well. But I think that social risk is really easy to measure because we just have to employ validated instruments, and some of them are quite brief. Our team has adopted those that are used in NHANES, and we collected data on education and income, just using 4 questions only in a relatively small cohort of individuals who have prevalent atrial fibrillation. And what you could see is that there is a progressive gradient between income and education with regard to risk to rehospitalization over the course of 3 years. A more complicated array is the FENX toolkit, and I think that there's been a push to integrate the FENX toolkit by the NIH, because obviously if we have standardized measures and they're well utilized, then they can speak across studies. I think that the social risk measures in the FENX toolkit are much more comprehensive. They include marital status and home ownership, dividends, vehicles, businesses, stocks, annuities. And our experience was that our participants in our studies, they really couldn't tolerate this array of questions because it was so long. And also the detail was just excessive for them. So I think that the standard questions from NHANES are simple, they're easy to implement as well, and they show validity too. I think that one of the concepts in thinking about social risk is that it has a lifetime course. And so the Moli-Sani study is a cohort of individuals from central Italy, and they were able to ask how low SES in childhood relates to outcomes in adulthood in a cohort of adults who are ages 30s to 60s or so. And what they saw was that people who had their educational and material trajectory upwards did a lot better than those who had stable low or those who only had education. So people who were able to have a better composite SES certainly did better. In heart failure, the study examined social risk and saw that that social risk was associated by a gradient again with increased risk of heart failure hospitalization over the course of about a decade. What I think is interesting about this study is that it was conducted in central Italy, in the Naples region of Italy. That's where, if you've seen the HBO series or read the books by Elena Ferrante, My Brilliant Friend, takes place. Those novels, they're really seeped with poverty and the degradation that people have and that they experience in terms of their poverty. And so this study asks not just about education and occupational class, but about the availability of hot water and residential overcrowding, which are factors that I had never considered even as relevant to some of our participants in our studies. But again, I think this shows that, or suggests that there is a definite contribution of early life experience towards health outcomes. Health literacy is something that I'd like to emphasize today, because it's been hypothesized as one of the mediators for the association of childhood poverty with adult health. Health literacy is defined as the ability to obtain, process, and understand health information. It has multiple dimensions. It includes reading, numeracy, writing, oral communication, but it also conveys the ability to use technology and digital resources to navigate care, participate in shared decision-making, and adhere to therapies. It's increasingly appreciated as a social risk factor and has been shown to mediate racial and ethnic disparities in health outcomes. It's really important to pay attention to, because the most robust estimate of literacy suggests that up to 36% of US adults lack basic literacy. Health literacy is highly interrelated with social disadvantage. We see a lot of patients who have limited English proficiency. At New Haven, I would think it's probably the same thing. There is a nice literature on how the discordance between patient and physician has worse outcomes, actually, in terms of primary prevention than those who have concordance, language concordance. And individuals who are at risk for limited health literacy may have cognitive impairment. It may be because of adverse life circumstances or other obstacles to equitable care. Health literacy has an array of costs that are important to emphasize across multiple disease states, treatment, and outcomes, both cardiovascular and non-cardiovascular. And because of my group's interest in early life exposure, we were kind of fascinated in one of our journal clubs by this study here on your left, which looked at literacy at an early age. So you might have heard of the 30 million word gap. That's been kind of debunked because it's a very limited sample set. And the recordings of families were quite limited as well. That study's been criticized as having a lot of bias. So what I just present here briefly is just household recordings over the span of 6 months to 3 years to measure early life language exposure. This study was 8 times larger than the prior study, and it really showed that speech exposure differs by parental education. We wanted to capture a similar conception of health literacy extending over the course of the life course in our AHA statement on health literacy. And we included this figure in the statement to indicate the multifactorial contributions to limited health literacy that begin at a very young age and extend well into adulthood, and that occur well before we meet our patients. So there's lots of different opportunities for health literacy to be limited or to be enriched, extending across the life course. Of course, life course exposure to social determinants is not just in the home, but where we live and our community also has a really important influence. And I think these data are a little bit limited because they're over 20 years old, but I think that they're highly compelling. Here, what the investigators did was they looked at per capita income, according to census tract, in relation to mortality in 282 cities in the United States. But they also looked at income inequality in those cities as well. And I think what we could see is that there is a joint contribution. So having less income, as we already saw at the start of the talk, is associated with longevity. However, where we live in terms of the community and the community-based resources, in terms of income inequality, also contribute markedly towards people's death rate. So they examine not just the effect of per capita income, but this notion of income inequality, which can be measured using various indices here. The study, again, it was conducted, published in 1998, and I think income inequality, as you all know, has grown enormously over the last 2 decades. So I think this merits replication. But I think what this shows is that it's not just our own capital, but also where we live in our social context that influences our outcome as well in terms of our health. So this, again, this I think is also striking for us to keep in mind in terms of thinking about our community. There are lots of indices for looking at income inequality, and you may have seen the increased use of Area Deprivation Index. Area Deprivation Index, or ADI, is pretty easily extracted. You can turn any address into a federal information processing standard or a FIPS code, and you could run it through the neighborhood atlas at Wisconsin. ADI is then scored progressively from 0 to 100, with higher scores indicating greater area deprivation. It's a summary of 17 different factors that are gathered at the Census Block. For those who are not familiar, the Census Block is part of the census tract, and it's roughly 600 to 3,000 people. So it really is essentially a neighborhood. The upside is that it's very easily available. It's no cost. It's highly validated. You don't need to have geocoding skills. For instance, at Yale, you've had a very successful study, prompt heart failure. I attended the ACC this year, and I heard about the study. And I know that many of you have contributed to that work. And maybe one thing to think about is, as a secondary post hoc analysis, is to consider using patient addresses, measuring their ADI to see if there are areas that have less access to essential cardiac therapies, like you've been able to provide through prompt heart failure so nicely. I think the downside is that it's an index. And so again, it's a compilation of 17 different factors. So it doesn't provide the individual data points. And you could look at it at the state level. So here's Pennsylvania, or you could look at it at the national level as well. And I just want to show a couple of examples of where we use this, because I think it's illustrative of University of Pittsburgh Medical Center, where I am on the faculty here and I'm a cardiologist, but also its utilization here. So here, UPMC, it's about 40 hospitals in Western Pennsylvania, extending to the central part of the state and also to Southern New York and into Maryland. And we examined area deprivation index in association with 1-year readmission in individuals who'd had a cardiac admission. And what we saw by looking at ADI per quintile was that there really is a kind of a graded association with readmission rates. And I think this is important feedback to the healthcare system, which is that those individuals who are admitted are at very high risk based upon their area deprivation for readmission, actually. And this was led by my colleague, Dr. Johnson, and published just last year. And so we also recently asked what the effect was on anticoagulation in individuals with atrial fibrillation. And I was very curious about this because I had participated in studies that had examined disparities in provision of anticoagulation as well. You know that atrial fibrillation is associated with stroke, and that people with atrial fibrillation, our guidelines indicate the importance of anticoagulation, in particular use of the direct-acting oral anticoagulants. But there is really variable treatment. So we examined a cohort of individuals who were identified with atrial fibrillation, incident atrial fibrillation, across a 5-year time frame, 20,000 people, a very large sample size. This was led by one of our medical students, Talu Amali, and he presented this as one of the at the AHA EPI meeting this last March in Chicago. And what he found was that essentially, as area deprivation quartile increased, we see that people are less likely to be prescribed an oral anticoagulant. And among those who are prescribed an oral anticoagulant, they're less likely to get a DOAC, a direct-acting oral anticoagulant, as opposed to warfarin. This is really a report card on the healthcare system, which is that, after you exit the top quartile, you're much less likely to receive anticoagulation. Again, guideline-directed medical therapy. And this is really, I think, it serves us well as a benchmark in terms of a failure to treat patients who experience social disadvantage. So this is noteworthy, I think, for us. So the last study to present, in which we looked at more locally, is I think it's something that I'm most proud of as far as these projects, because of the immense amount of work. So we were able to extract patients from the electronic health record. We geocoded their addresses, and then we looked at their residence, and we leveraged an ongoing monitoring program of particulate matter exposure here in Allegheny County. You may know that there's a long legacy of the steel mills and coke plants here in the Pennsylvania, Western Pennsylvania region. It's created an enormous legacy of pollution that has lingered to this day. Apparently, Pittsburgh remains one of the most polluted cities in the United States, despite years of trying to clean this up. So what we did was we took people's residents, we took their electronic health records, and we used census level data to adjust for social factors in order to look at how particulate matter was associated with stroke risk and individuals in our healthcare system with atrial fibrillation. This was led by junior faculty Zach Reinhardt, and what he showed was that over the course of 10 years, residential level pollution exposure was associated with increased likelihood of stroke, regardless of whether or not people received treatment. This was just an immense amount of work to tie together these multiple data sets, and we were really pleased with the result here. And I think this also shows what the effect is of pollution in our region. So I think there's a real public health contribution. I want to return to education because, as I said, I think it's just so important. This is one of the largest studies of education, looking at educational attainment and mortality, and it was conducted in Europe across multiple countries. And here, the investigators used a standardized mortality rate to the European population and looked at individuals who were aged 30 to 74 and compared those who had low education across 2 decades versus those who had higher education across 2 decades. And what's remarkable is that this is a longitudinal analysis, multiple decades. The results are consistent over time. It's multiple nations, so it's a pretty massive study. These are diverse societies with diverse healthcare systems, and the findings are congruent and uniform. which is that there is a marked difference in terms of mortality based upon education. Dr. Johnson, my colleague as well, looked at education in NHANES and stratifying by race, looked at the association of education with the components of Life Simple 7, a really easy, very, very accessible metric for examining cardiovascular health and categorizing it as ideal, intermediate, or poor. All of us are probably familiar with Life Simple 7 because it's been well utilized. In her multivariable adjustment, what she found was that those who were non-Hispanic white achieved ideal health with increased education. That is, those who were a college graduate or above versus those who had less than high school had a fourfold higher odds of achieving ideal education. In contrast, individuals who were non-Hispanic Black were far less likely. So education was not enough to move the needle across the racial and social groups. Our discussion summarized how education is a necessary but not sufficient factor to overcome social risk. One of the large contributors towards differences in social risk is median wealth and the wealth gap by race in our country. So we began today by articulating the very evident gradient between household income and lifespan and longevity. And what we present here is the enormous wealth gap between Black and white households, which is across decades preceding 1989, obviously, but such that the median white household has about 8 times the typical Black household. This is an enormous difference in terms of resources and assets that can be leveraged. So, of course, education is not enough to promote ideal cardiovascular health in those who lack household income. And I think that, again, we could focus a lot on race in terms of talking about social risk. And Dr. Erica Spatz, your faculty member, has written about the complexity of race as a social construct and the need to include structural associations in its measurement. Like me, you've probably read a lot of studies that have focused on race and disparities, but what are they missing in terms of the way that they examine race and the way that they examine how race contributes towards disparities in cardiovascular care? There are an immense number of factors that we could include that are the underpinnings of structural racism and determinants. These include segregation, the built environment, neighborhood social factors, social and food environments, social status, and social experience. And there are others that you could add here as well. So I think this is worthwhile in terms of walking through a demonstration of some work that I participated in with regards to looking at racial differences in an outcome. And so this is a case study, if you will, about racial differences in the Atherosclerosis Risk and Community Study. You may be familiar with the ARIC study. It's a cohort of about 15,000 people, and they're divided between Black race and white race, about 5,000 and 10,000 each of these groups. And I would note that the Black participants in the ARIC study, they come from Jackson, Mississippi, and that's the foundation for the Jackson Heart Study. And so what we looked at is in people who developed atrial fibrillation, what were the rate differences across these outcomes: stroke, heart failure, coronary heart disease, and mortality. And what we saw was very striking differences here, right? Where you can see that those who had Black race were far more likely to experience these outcomes. So this was like headlines. And I actually had been in Pittsburgh just a month, and this was published. And so it was a lot of attention, and it got coverage by the New York Times. So the hometown newspaper, you know, it's really good for your mother-in-law to kvel when you get that kind of coverage. But the point that I want to make with this is that the author of this summary in the paper wrote that the reason for the finding is not clear, but the study had no data on treatment or treatment disparities, which might partly explain the outcomes. And I pushed back because I said, actually, these communities are really disparate in terms of where people come from. And maybe there are factors that contribute to these differences that have nothing to do with the treatment that they get. And so looking under the hood a little bit at the ARIC sites, and I included New Haven here for your interest as well, you can see that those who live in Jackson, Mississippi, compared to the other ARIC sites, have really striking differences in terms of poor or fair health, access to primary care physicians, and lack of insurance. So given the health disadvantages at various life stages, it's really no wonder that we see differences in outcomes by race. And I think this is a profound lesson for us in terms of the way that we look at race and measure it in our studies as an independent variable. In fact, it goes deeper than that, because Jackson's social profile reflects enormous inequity and disadvantage. For instance, just a few years ago, Jackson, Mississippi was recognized as one of the most obese cities in the United States. In response, the city started a municipal campaign to recognize the absence of healthy food choices and the fact that the city of Jackson is kind of a food desert and a food swamp. And I've had really good conversations with Dr. April Carson, who is the PI of Jackson, about how the study has a responsibility to bring health to the community by addressing this. And you could also say, well, if obesity is so high and higher than the other cities that participate in ARIC, for instance, then we know that obesity is associated with stroke. We know it's associated with heart failure. We know that it's associated with lots of other health complications. And so again, no wonder people who live in this context are much more likely to have adverse health outcomes than those who live in other contexts where they don't live in a food swamp or a food desert. There's a lot of food insecurity in Jackson as well, also unmeasured by our study. And so we need to address this epidemic of a food swamp or food desert as a menace to public health, as opposed to capitalizing on racial differences in terms of outcomes in a study that doesn't include these very salient variables, these very salient exposures that influence people across the life course. Likewise, if we look at atrial fibrillation, these are people who are older. And so maybe some of them are on Medicare. I showed the huge disparity in terms of household wealth, median and average, across white and Black households. Medicare beneficiaries also have this. There's a tremendous difference in savings across race as well. So again, this persists as well into adulthood, this wealth gap extending across people's lives. And so here's a framework for looking at social risk as a life course perspective. It's one summary of a life course perspective of health, showing opportunities for enhanced opportunities for health across various life stages, where social context and health mutually reinforce each other. And also, I think, suggesting that health occurs in a social context and it's not isolated. And so our patients who are successful with their chronic disease, they may be successful because across birth to being an older age, they have increased opportunities. But to me, this really seems two-dimensional. And I think there's a lot more that we could put into our conception of health across the life course. For instance, in birth and childhood, we could look at housing. Like the study from Naples, we could look at crowding and food security, neighborhood safety, environmental safety. I emphasized parental health literacy because I think that's very important to how people have access to primary services with regard to preventive health care. In adolescence, people's school quality and their opportunities for recreation, their social stability as an adolescent, as well as their social resources, how these factors are associated with long-term cardiovascular health really is not measured. And so kids who have parks and Little League and different recreational opportunities, that has a tremendous influence on their cardiovascular health as well. Health insurance, obviously, we've emphasized, but also vocational opportunity and opportunity for promotion. And this is where some of the structural factors and structural racism, I think, come into play very much so. How does leisure and the ability to have recreation during adulthood For those of you who went to the gym before this talk or are going later today, that certainly is an important part of your composite health as well. And also self-care too mediates health outcomes. Finally, in older age, access to preventive services. So what does it cost to have home-based services and have people come into your home to help you? What kind of financial resources do you need to have? And how does keeping you out of the nursing home further your longevity as well? Social connectivity is really important. People who are isolated have worse health outcomes. And finally, ancillary services. There are multiple that essentially will improve lifespan, and they'll also improve patient-centered outcomes like keeping people out of the hospital. So once again, wealth drives health. Here's a contrasting view of a framework of social risk. And I think since the onset of the pandemic, we've heard this term syndemic used very frequently. But syndemic is not a new term. It refers to the concurrent social, structural, psychological, and medical or clinical factors which conspire to aggravate health outcomes. Social work has long referred to this as the biopsychosocial model of disease. And if we accept this framework as being valid, then we have to say that we're not merely technicians who diagnose and treat disease, but have to consider the underlying social causes that aggravate and perpetuate access to healthcare as well as health outcomes. So I really like the syndemic model because of the way in which it can bring in these different aspects as layers, each of which contributes and reinforces each other for a meshwork that perpetuates disparities. So the implications here are, in terms of social risk and cardiovascular disease, are, we can quote Wittgenstein, the limits of my language are the limits of my world. We've shown that social risk exacerbates cardiovascular disease. It worsens access to care. It increases likelihood of mortality. We've shown there are interrelated, intersectional, and reinforcing mechanisms. These occur at the individual level, the neighborhood level, they occur at the societal level. So we are enmeshed within them. But why are they not collected routinely in trials and registries and observational studies? Why is it that table 1 of every study that we published only has race, and very few even have household income or educational attainment? Why that drought? And if we say that social factors are so important in terms of the magnitude of their contribution to health outcomes, why are we just ignoring them in terms of our trials in order to assess their validity, in order to understand their generalizability? What would it mean if a trial was published and it showed not just that the individuals participating were predominantly white race, but also that they were all college educated and they were all middle to upper class? What would that say about the trial? What would that say about whether or not it is legitimate? And as well, this deficit, how does this inform our professional society guidelines? And I would argue that I am part of the American Heart Association and I use these guidelines, but these guidelines, they occur in what I consider to be a social vacuum. So the people who enter studies, there's a selection bias, right? They're more likely to be white race. We know that when we're working a lot on trying to increase diversity of our trials. But we don't know whether or not they can read or they have assets, they have social resources, whether or not they're rural. People who are rural have very limited opportunities to participate in clinical trials, and they also suffer enormous adverse health outcomes. From these selection biases, we develop studies, and then we have an iterative literature. And the literature reinforces what our practice is. And this goes into forming guidelines. We get with the guidelines, and we have an array of studies which show that treatments are successful. But what about the fact that not all treatments are given to all people? How does the selection bias inform the propagation of disparities? Which is to say that the guidelines are really important, but even as the guidelines show success with regard to treatment, who do they leave out? And so people who aren't able to get guideline-based care, those are the ones who continue to fall behind. And so putting this together, I think this is a figure which came from an editorial that I wrote that was rejected, but I just want to show it here because I think I tried to use it to summarize the way in which we could transform the guidelines to build in these different components. And so I think that we can bring in greater social diversity into our studies. We could bring in social measures into our studies. I showed you a few things. It would be very easy for clinical trials to at least look at area deprivation and to be able to understand how area deprivation may influence trial enrollment or else the results. We could look at medication copays and financial costs and barriers because we present these guidelines as being the first line therapies for our patients. And I'll get into that a little bit more. And I would also like us to incorporate health literacy into guidelines because we assume shared decision-making, right? The cholesterol guidelines advocate and push for shared decision-making. It's something we're expected to do. But what is the evidence-based shared decision-making model? And how do we use that across multiple different populations that have social diversity? These are really important challenges. And I think what I would say is that the guidelines kind of shirk them. And I think we need a new generation of guidelines then. So that being said, what are we going to do in terms of our clinical practice and in terms of measuring social risk? And I think we have here the public health impact pyramid. Usually we think about the public health impact pyramid, people have used it as a hierarchy for looking at how interventions affect change, with increasing population impact going down the pyramid and increasing individual effort going up the pyramid. And looking at social determinants, I think that one thing we can do is we can ask people in our exam room how long they've been in school. We can assess their general literacy and their reading comfort. If we ask our patients about their education level and about their social resources, we'll learn an enormous amount about them and about what their capacities are. We can look at copays and whether or not they can afford the medications that we're describing and obstacles to care. I also mentioned green spaces here, and I talked about Jackson and the Jackson Heart Study. We can ask who they live with and their English proficiency and whether or not they can pay their own bills. And so just kind of thinking about these two, education as well as copays, I think we can focus here as well. So health literacy is really easy to screen for. There's a 3-item screener that's shown here. It's been well utilized. It was implemented at Vanderbilt in the emergency room as well as the ambulatory visits. And therefore, people knew what the health literacy was of the patients they were treating. In our research, we use something called the newest vital sign, which is publicly available and is 7 questions. And I think when we think about interventions to overcome social determinants, there are very practical strategies for considering health literacy. And in the exam room, they can consist of things like avoiding jargon, encouraging questions, I think is really important. I want to emphasize that when my patient doesn't have a question about their heart disease, to me, that's a troubling sign. It's an indication that maybe they don't know how to ask the question, basically. In the institution, there's this concept of a health literate organization. But what I want to share is that in terms of readability assessments, in my institution, people who get a left heart catheterization or right heart, they have a consent that's a 12th grade reading level. A defibrillator implantation is at the 13th grade. People undergoing a cardioversion, it's at the 11th grade. The consent for my studies, we write it at the 6th grade level. Then the IRB insists on a bunch of language that's legal, and it elevates the reading level to the 12th grade. And so as far as interventions, I think what we can look at is copays and medication access. And here's a study, again, that Dr. Johnson, my colleague, is doing, and I think she's going to be presenting this at QCore this year, in which she looked at people's household income and the likelihood of being prescribed Entresto, sacubitril valsartan, within 6 months of a heart failure diagnosis. And what she found was a very steep gradient in terms of people who are able to get this medication. And likewise, the adherence to this medication by household income sharply differed across household income. So this speaks to the financial toxicity that your colleague, Dr. Harlan Krumholtz, articulated so well at last year's AHA scientific sessions, which precludes people who are prescribed medications even being able to adhere to them because they are non-generic medications and they cannot afford the excessive copays. And this is a recent note that was in the Annals of Internal Medicine. It was for hospitalists, and it's a clinical pearl on heart failure optimization. There's this enormous attention now towards quadruple therapy, the polypharmacy. And what these heart failure specialists wrote were that insurance coverage, prior authorization requirements, or out-of-pocket costs may be barriers. But if they arise, just give the medication anyway, because maybe the multidisciplinary team will be optimally positioned to explore all possible strategies for securing patient access to medication. And I just think that that's unrealistic. And I think that we can't have this attitude that we can just prescribe. We actually need to assess if people can take the medication, if they're going to have access to the medication. And so this is just looking at adherence to glucagon-like peptide 1 receptors by insurance and copay. Again, finding that as copay increases, people are much less likely to demonstrate adherence to these medications. This is what we're going to see, which is that we have guidelines that tell us, again, that we need to structure care and be very aggressive in terms of polypharmacy. But what we do is we widen disparities as a result. So I don't have time actually to go through my trial. And if I could ask for a rain check, perhaps I could come to Yale in the future and I could present the studies that I'm working on. So what I'm going to do, if you don't mind, in order to have some time for us to talk, is skip through a bunch of slides that describe this trial. I think you'd be interested in it, but just in the interest of time, I apologize. So I'm just going to go through quickly, and if people want to talk about the trial, then I think we can do that. Just one thing that I want to highlight is that this is a patient-facing trial, and it's about enhancing people's confidence in their ability to manage their chronic disease. And so we enroll a lot of people who have never used a smartphone. We teach them how to use a smartphone. We have a newsletter, and I also really like that we have the birthday cards that we send people every year of the trial to remind them that we're thinking about them. So getting back to the public health impact pyramid, I think there's opportunity for us to make an enormous difference, even simply by working with individual patients, that goes right down the impact pyramid and has very dramatic effect. And that is by considering their health literacy, considering their life course of social deprivation and how that's impacted their experience of their care. And then also considering their current status and whether or not they can afford the care that we think that we're prescribing to them. Okay, overall summary here, I'm wrapping up, is that social risk contributes prominently to cardiovascular disease and health outcomes. And I think we've demonstrated this today at the individual and neighborhood and community levels. There's been extensive research that wealth brings health. It's great to be wealthy because you'll live longer. And I think that a simplified lens does not adequately capture the longitudinal and multiplicative impact of social factors in terms of aggravating risk for a disease. We can work at the tip of the impact pyramid. Even those of you who are clinicians, you can find out from your patients how they experience their healthcare and what their social barriers are, what their social experience is. That can have really important effects long-term. The next steps for our field are, I think, to integrate social factors into our trials and our observational studies for the arguments that I've made. I would like us to enhance social diversity in investigations, not just race and ethnicity, but also income and education. And morality, I think, is a very important contributor towards health outcomes that has to be clearly investigated further. I think we can expect that guidelines recognize social risk and anticipate their effects on health outcomes. And therefore, we can avoid widening the gap between those with and without access and assets. a lot of acknowledgments. I really have a great team here in Pittsburgh. And I have collaborators still in Boston. I moved here a little over 5.5 years ago. So I think with that, I'm pleased to take questions. I want to thank you for attending today, and I'm looking forward to speaking with you. Thank you so much. I'm going to stop sharing my screen now.
Dr. Magnani, thank you so much. This was a really terrific and very interesting talk, presenting data that really spans the life course and the challenges that we face when we meet a person. I was particularly interested in some of the very early health literacy data that you showed, and how much of a mountain we have to climb, to really overcome the challenges of decades and even generations of social deprivation that our patients bring with them. I wondered if I could use my question and in a little bit of time to ask you about the early thoughts on this study. It seems like, I'm very curious to hear how you've put some of those concepts and challenges into the study that you're embarking on with AFib Lit. And, who are the partners in that study? How did you bring together a team to really think about how best to overcome those challenges?
So thank you so much, Dr. Spatz, for your question. And again, I apologize to the group that, clearly I had more content than I had time for. So these are really great questions. I would like to tell you about the study. So we developed a smartphone-based agent that functions like an avatar and a health coach. And we essentially recruit in rural Pennsylvania, and also try to target patients who would classically be considered underserved, here in the Pittsburgh region. We've had great success with using remote engagement during COVID, and in fact have been able to exceed 100% of our goals. And that's because of my team in terms of their aptitude for conducting the study. We developed the agent such that people who had limited health literacy would get training in how to use a smartphone. That's an enormous amount of attention that we spend with them. We provide the phone to people at no cost to them. They could use it for however they want during the study. I think the downside is that we have to get the phone back. We provide an intervention, but then we take it away from them, basically. And for some people, it might be a life-enhancing intervention, right? Having a smartphone. So we recognize that. I recognize that as a limitation of the study. The curriculum that we provide people is essentially very patient-focused in terms of recognizing obstacles to adherence and challenges that they have with their health. So one example is we provide strategies for addressing adherence. So we help people recognize intentional and non-intentional adherence and strategies to overcome that. We also have a place where in the application itself too, where people can provide lists of questions, where they can develop lists of questions over time. Then they can collect those questions. And then what they can do is they can bring that to their doctor's appointment, and they have a list of questions for their doctors. It's really interesting to me that some people really enjoy using this agent so much. And you just saw a brief picture go by, and I'd like to tell you more about the agent itself, but it speaks to social isolation, that people, particularly during COVID, they really were engaged by essentially an avatar that provided them with attention and support. And the agent uses anecdotes and stories. The agent is humble and is kind of a coach and a companion to help people overcome social obstacles to medical care.
Interesting. That's terrific. Does anybody have any other questions? I know we're at the top of the hour. Okay. With that, I want to thank you for a really terrific grand rounds, very provocative and inspiring. And hopefully, I think we could take some nods from the work that you're doing at Pittsburgh and bring that to Yale. So thank you so much for joining us today.
Wonderful. Thank you for having me. I really appreciated being here, and thank you so much.
Absolutely.